We have a limited time, and most of all, we are just before the launch time. So I'd like to focus our discussion on the one or two drugs, especially corticosteroid and long-acting beta-2 agonist. Okay, corticosteroid was widely used due to its very potent anti-inflammatory and immune-modulating effect. But corticosteroid is a two-edged sword, that it causes many kinds of adverse reaction, for example, psychosis or the infection due to immune suppression and adrenal insufficiency or the osteoporosis, something like that. And the first, the adrenal insufficiency. This table shows that crude and adjusted odds ratio of hospitalization for adrenal insufficiency associated with current, recent, and past use and every daily dose of inhaled corticosteroid. This data comes from the healthcare data of Quebec, Canada. Observation period is 15 years, and they found that the current use means that inhaled corticosteroid within the 90 days just before the index date. That is hospitalization for adrenal insufficiency, and recent use means the 91 days to 180 days, and the past use means that the 180 days and the 1 year. And they found that the current use of inhaled corticosteroid, and especially the high daily dose, this dose means the fluticasone equivalent dose. That is, someone who used over 1,000 microgram for fluticasone equivalent dose had a great risk for the development of adrenal insufficiency. The odds ratio is 1.84. And pneumonia and asthma. This data also came from the healthcare data of Quebec of Canada, and the observation period is 17-year-old. They found that the use of inhaled corticosteroids significantly increased the risk of pneumonia and asthma. The adjusted ratio is 1.83. And very interesting, their second analysis shows that the dose, they could not find any dose effect. It means that even the low dose inhaled corticosteroids is associated with increased risk of pneumonia in asthma. Then they also found that there is no formula difference. That is, the budesonide or fluticasone and any other inhaled corticosteroid showed no difference. All of them showed increased risk of pneumonia and asthma. But they performed the sensitivity analysis because the early stage of pneumonia and early stage of asthma exacerbation, we cannot easily differentiate. So they performed sub-analysis to reduce the protobiotic biases. That they exclude the subject who used the ICS just 15 days before the index date. But the subsequent analysis also showed increased risk of pneumonia in the patient used inhaled corticosteroid, about 40%. And the COPD. I don't think that the pneumonia and the ICS problem in COPD are hot discussed before. So I just briefly showed the summary comment by European Medicine Agency's Pharmacovigilance Risk Assessment Committee. And they provide very interesting comment that this increased risk should be considered a class effect with ICS medicine. Well, this is the point I will discuss later. And from here, I'd like, as I said before, we don't have to discuss the ICS and pneumonia in the COPD, but as the investigator who performed the first study that's showing the association between the hypothalamic problem and the ICS use, they found that the patient with COPD has a little bit greater risk compared to the asthma patient in the development of hypothalamic disorder. So, and the tuberculosis, I'll show you later in my slide. The risk of tuberculosis is a little bit higher in subject with COPD compared to the subject with asthma. So I think it is a very good point to be discussed that the subject with asthma, subject with COPD has more susceptible or more easy to develop adverse reaction in treatment with the inhaled corticosteroid compared to the patient with asthma. And the hepatitis B virus reactivation. As you know that the hepatitis B reactivation and pulmonary TB is a rare event. So in the Korea, it's not low prevalent area. It's a good area to evaluate the effect of inhaled corticosteroid for the development of HB virus reactivation and pulmonary TB. This study performed by our own university hospital, a little bit old one. We evaluate 198 subjects with asthma or COPD who were treated by the inhaled corticosteroid and review the medical record retrospectively and found that the HBV reactivation was considerable. But ICS only user, as compared to ICS only user, ICS plus continuous. Continuous means 3 months or longer use of oral corticosteroid. The ICS plus oral corticosteroid user is a significant higher rate of reactivation of hepatitis B virus. And for the TB, one of my colleagues reported that the risk of TB, the patient who used the inhaled corticosteroid is about 20 points higher compared to the non-user. This is the result recently published in JACC in Practice by the Professor Kwon, one of the panelists. It's a very, very interesting result. They evaluate the risk of TB development after stopping inhaled corticosteroid. They found that the x-axis is duration of after stopping ICS, and the y-axis is number of TB development patients, and the dashed line is the average based calculated from the TB incidence in Korea. They found that even after 3 years stopping ICS, the increased risk TB development is observed. And this risk, as I said before, is a little bit higher in patients with COPD, regardless of type of the ICS. And bone mineral density. This is the study performed me and my mentor, Kellan Tantishira. And we evaluate the bone mineral accretion in the pediatric patients enrolled in the CAMP trial. You know that the pediatrics need to increase their bone mineral density. We performed the genome-wide association study with the oral corticosteroid, the total dose of oral corticosteroid and the bone mineral accretion, and found that 2 SNPs, as you can see the whole population graph, the cumulative dose of oral corticosteroid shows a negative significant correlation with bone mineral accretion, and the 2 SNP we found, the dose response, that the number of mutant allele increase, the strong negative correlation between the cumulative dose of oral corticosteroid and bone mineral accretion showed. And this is a study for the same population, but different analysis viewpoint. We performed the genome-wide association study with the final bone mineral density with the cumulative dose of oral corticosteroid, and found that 1 SNP is significant with genome-wide significance. And we can calculate the last BMD based on the equation obtained from the cumulative dose of oral corticosteroid and the final bone mineral density, and transform that to Z-score. This is ideal person who enrolled the CAMP trial whose cumulative dose of prednisone is 4,000 milligram, and after 4.3 years of follow-up period, if we remove all the other variables, which is maybe related to the bone mineral density, then the G-score with the point here, it means that we can, if we remove all other variables, then only the steroid, for steroid use, only the steroid use of 4.3 years, the bone mineral density reduced here. This means that the steroid use is very, very strong factor associated with bone mineral density. So I'd like to suggest some kind of a discussion point that do you think that these are the real problems? And if so, how do you handle these problems in your real practice? And the second one, as you know that the oral viability and particle size, protein binding is, the PK/PD parameter is very important for the to show the effectiveness of inhaled corticosteroid, and there is no head-to-head comparison the effectiveness of inhaled corticosteroid. I mean the corticosteroid formulation, but it is neither it also there's no scarce data in terms of the adverse reaction. Some said that lipophilic fluticasone had large area of the volume of distribution, so they stayed in our body for a long time, maybe result in the adverse reaction more frequently. And some said that they stayed in the epithelial fluid and causes more pneumonia compared to the other formulation. But some say that just kind of a channeling effect, that the new drug or potent drug, some GPs use the potent and new drugs for the more severe patients. So the prescription difference may cause this kind of difference, some say. So I'd like to, especially about the poor, that this formula difference may associated with the occurrence of adverse reaction. And the last thing is, how do we select or how do we predict the patient who will develop the adverse reaction in response to the inhaled corticosteroid treatment? Michael shows very good stretch for this problem, that genetics takes a breath. This is a very fascinating title, and I like it. So I'd like to ask the expert panels that do you have any clinical or including pharmacogenomics to predict the patient who will develop the adverse reaction in your treatment? Or the last one is LABA. You know that the use of pseudoactin beta-2 agonist is associated, regular use of pseudoactin beta-2 agonist is associated with the adverse reaction in the asthma. So now we do not use pseudoactin beta-2 agonist only or long-acting beta-2 agonist only to treat asthma patient. But the problem remains, especially for the ICS-LABA combination. So the FDA holds a stance that the FDA boxed warning and asked the pharmaceutical company to gather the information for this issue. And later, in 2018, the results from the big studies have published, and the FDA showed that there is no increased risk if the LABA if the LABA administered the patient with the ICS, then they removed the FDA's boxed warning. I think it's very, they said it is very, very unusual occurrence. But there are also some debate for this decision. For example, patient with a history of life-threatening or unstable asthma were excluded from the trial I've shown before. And the efficacy reduced the rate of exacerbation that requires the administration of systemic corticosteroid, but none of them showed a decrease in asthma-related hospitalization. Then there are also some issues related with risk calculation and timeline and size. And some said that labeling this trial as safety studies suggests that LABA have some direct toxicity that cause death or risk to hospitalization. There is some debate. So lastly, I'd like to discuss here that do you think that safety issues related with LABA in patients with asthma have been cleared? And how about the patient with COPD? Okay, this is the end of my presentation.
Thank you very much for addressing important issues.